I'm going to speak primarily about the increased incidence of gout in the patient with diabetes. And if you're not looking for that, perhaps this will get you to look a little bit more often. I have no conflicts with this presentation. So in the diabetic foot, we have certain disorders that are found more commonly. And some of them have to do with aging. So we have certain problems that we see with increased frequency in the aging patient, in the patient with who's obese. We certainly have bone and joint pathology that occurs in association with chronic kidney disease or end-stage renal disease, such as renal osteodystrophy would be a perfect example, calcification of vasculature. And you want to remember that in things like aging, chronic kidney disease, that we get osteopenic changes. This can result in subtle avulsion fractures or stress fractures. It's unappreciated by the patient because of their sensory neuropathy. And I think at times this triggers a Charcot joint. And then effects of many of the medications our patients are taking that can affect this. So there's a number of bone and joint disorders that occur with increased frequency in the diabetic patient. I'm going to address gout this afternoon, but other forms of crystalline arthritis are much more common in diabetic patients, such as calcium pyrophosphate dihydrate disease or pseudogout, or hydroxyapatite deposition disease, dish disease. You get large heel spurs, you get large spurs everywhere, ligaments attached to the foot. So you may see that occasional diabetic patient that has these large bone spurs all over the place. If you take an x-ray of their spine, you'll see posterior bone spur formation. It's really not hard to recognize. You're going to see it on at least 3 consecutive segments. It does not affect the posterior zygoapophyseal joints. It doesn't pinch any nerves. Osteoporosis occurs with aging. It occurs in our diabetic patients. And of course, this can result in its own specter of problems. Secondary hyperparathyroid disease, again, these patients with kidney disease. They have problems with vitamin D because, as you know, the number 2 position in vitamin D that is activated in the kidney. So you have 125 dihydroxycholecalciferol and then 125 hydroxycholecalciferol. If you don't have vitamin D, you can't absorb calcium. Without calcium, you can't live. Calcium is involved in almost every body function, from your heart beating to your mitochondria to everything else. And calcium, as you know, is regulated in a narrow range. You have to get calcium from somewhere. You break down the bones. Unfortunately, the osteoclast doesn't just pull out the calcium, it's got to break down the entire bone. So this increases our fracture liability, delays fracture healing, and then vitamin D deficiencies for many reasons, aging, particularly in minority patients. Vitamin D deficiency is very, very common. It can also be associated with neuropathy. So when you work up patients for peripheral neuropathy, if they're a minority, you might consider getting vitamin D. So gout is the one I selected to talk about. And we have diabetic patients that come in with toes that look like this. And we right away got to think infection first. We take our x-rays. We may see some bone destruction. If they have a keratotic lesion or some superficial abrasion or ulcer, we jump to the conclusion that's osteomyelitis. Here's 2 recent cases I had. One is a middle-aged patient. He had a TMA done elsewhere, and they did it through the metatarsal phalangeal joints. Rather large individual. It comes in with an ulcer sub 1, positive probe to bone test. I got an MRI. It came back osteomyelitis. I took him to the OR, assuming it was osteomyelitis. We made a dorsal incision, and all this gouty crystalline material was there. It was a tophi, and it was actually gout, and the patient looked like they had an infection. MRI called it osteomyelitis. I had another patient with cellulitis of the second toe with a soft tissue abscess, and again, the patient looked like they had an infection. We admitted them for surgery. I did an IND at bedside. Cultures came back OSSA. Bone marrow was negative on the MRI, and the specimens I took came back heavily loaded with uric acid. So we know several things. The incidence of gout is much higher in patients that have diabetes, and the incidence of diabetes is much higher in patients that have gout. And if you think about many of our type 2 diabetics, they're older, they're overweight, they've got hypertension, they're on medications that could elevate uric acid like like hydrochlorothiazide or something like that, and they have elevated cholesterol, so they have metabolic syndrome. We know uric acids elevate with aging. Women catch up with men as they get older, get postmenopausal, and this contributes to that. And then I always look at my patients that have chronic kidney disease because, as you know, uric acid is excreted. 2/3 of your uric acid comes out the kidney, and if you have failing kidneys, then you're going to have a predisposition to have elevated serum uric acid levels. Now, one of the things about gout in the older patient that you should remember, particularly the diabetic, number one, if they have sensory neuropathy, they're not complaining of the same kind of pain that that 30-year-old male is going to come in with that swollen, horrible-looking toe, and they're having intense pain, and they want immediate relief, so that you don't get that intense pain. And the gout tends to be more chronic in nature. So it's easily mistaken for something like, well, they've got a hallux limitus or a chronic bunion. And it's also more often pauci-articular. So again, we look at that typical 30-year-old male, maybe they're hypertensive, they're overweight, they got a stressful life. We figure they have classic gout, and it's typically one joint. Whereas in the older diabetic patient, it tends to involve several joints, and it could easily look like just a chronic osteoarthritis, or it could look like hydroxyapatite or anything else. So these are the differences between gout in the younger patient without diabetes and the older patient with. So don't forget it in women. And in my experience, the women who get it the most, number one, are under care for hypertension. And I think if you have gout in an older female patient, you got to evaluate them for peripheral arterial disease. As I mentioned, it tends to be pauci-articular or oligoarticular. So you may get several joints that are involved. Older patients tend to get more tophaceous gout than younger patients do. And again, if they're diabetic, if they're on a diuretic, that type of thing, then I talk to them about it. If you don't recall, the normal that you're supposed to go after is about 6 milligrams per deciliter. I'm so old, I remember when I graduated PCPM, the normal gout level was 10. And now we're all the way down to 6. So here's some examples. This was a patient had an ulcerating corn, top of the second toe. Foot comes in, they're swollen, not particularly painful because of the sensory neuropathy, and I'm thinking infection. I'm thinking maybe Charcot joint, and the foot swelled, and they had the hammer toe, and then they ulcerated secondary to that. Here's a patient came into teaching clinic and was diabetic, had this huge toe, somewhat painful, and we drain it and right in the clinic, and all this uric acid comes out. This is another patient, diabetic, came into the clinic, had an ulceration, so right away you're going to go, got it, diabetic, ulcer, vascular disease, need to rule out. And here's the x-ray, you can see it was gouty arthritis, and easily mistaken. This was a patient I was treating for a sub-3 lesion. I don't remember why I aspirated dorsally, but I did. This was from my private office, and I just syringed loaded with uric acid. This was one that came in with a swollen ankle. I was thinking Charcot joint, maybe possibility of sepsis. I aspirated the ankle and just loaded with uric acid. This was a consult I had at the hospital. The patient was scheduled for a below-the-knee amputation and had some open wounds, no doubt, had these x-ray changes. The internist, for some reason in this case, ordered bone scans. I can't tell you why, but they did. All this lit up. They told the patient that you've got osteomyelitis, the leg needs to be amputated. Turned out to be gout. When you do surgery in gout patients, keep in mind that they do have some increased incidence, some comorbid conditions and concurrent cardiac disease. About half of them have some difficulty in healing, and so sometimes I prophylaxis. This was a diabetic patient of mine, had an ulcer. I went ahead and just did a simple bump on the first metatarsal, take pressure off the medial head, blew up. So now I got a diabetic patient, little bit older, they're had surgery, they're red, they're swollen, they've got drainage, they're hurting, and you've got to keep control of them. And I warn patients at pre-op that I don't want you going to any emergency rooms, I don't want you to see anybody else, because I know your foot, and because I don't want somebody just looking at it and assuming it's an infection, because then things get out of hand. And this turned out to be gout. This was a diabetic patient of mine I just did a chilectomy on. That's all I did. I thought we'd sleaze this one on through. Stayed swollen, warm, painful, starts to get erosive changes. Again, it turned out to be gout. Same differential. You got to worry about, what's going on here. This was another one. All I did was a simple a chevron osteotomy, diabetic patient, a little bit older, blows up, gets swollen, red, warm, starts to drain, very easily mistaken for infection. So every now and then, if you think they got it, you go ahead and get a synovial biopsy. This one I did on a patient, fortunately, so I had firm evidence to go back and say this was gout. Here's was a more dramatic case. 66-year-old male of mine had a Charcot joint, collapsed his medial column, had an ulcer, had a pretty rigid deformity. We said once the ulcer's healed, we're going to stabilize your medial column. Went ahead and I did a medial beam or bolt. I think I did a beam and a plate medially, and this is what I did. And he breaks open, starts draining with an open wound right here, and had a wound dehiscence. The hardware is exposed. Gram stain showed gram-positive cocci. White cell count was 10.2. SED rate was 40. And this was my differential diagnosis. Obviously, infections, number one in my mind. Reactivated Charcot joint was number two. Possibility of inflammatory arthritis was number three. And in fact, the patient did have gram stains with gram-positive cocci, but it was also loaded with uric acid. So don't forget the possibility of gout in these patients. Always consider the possibility of hyperuricemia. Now, what about patients you haven't done surgery on quickly? One of the problems is your choice of medications, because no matter what poison you pick, there's some reason not to give it to a diabetic patient. So, I talked to them about if they have kidney disease, then, anything, colchicine, anti-inflammatories could exacerbate it. That's a problem. If they have congestive heart failure, obviously you got to watch your anti-inflammatories. Your COX-2 inhibitors have a significant cardiovascular liability because they don't inhibit thromboxane, or they don't inhibit the prostaglandins in the platelets, prostacyclin A2. They do inhibit prostacyclin, so you don't get the same vasodilation, but you do get vasoconstriction. Many of our patients have AFib or have stents, so they're on anticoagulants. Now you're prescribed an anti-inflammatory, you get the call from the pharmacy, you really shouldn't give this because the patient's already on a blood thinner. And so there's lots of reasons with it. And then steroids in a diabetic patient becomes problematic. It's been shown diabetic patients have double the risk of DVT. So if you're immobilizing any diabetic patient for any reason, Charcot joint, ulcer, whatever, even if they're ambulatory and you just immobilize them in a boot, prophylax them with something, because they have an increased risk of DVT if they're just diabetic, just by virtue of being diabetic. And gout also doubles the risk of DVT, increases the risk of dementia. So what I do personally is when they come in like this, I give them an injection back here. I use xylocaine with epinephrine or Marcaine with epinephrine. If you don't want to use epi, don't do it. I do. I don't circle the toe. I do a big V block like this dorsally, and then I go see some other patients, let it spread out. Then I come back and inject the joint, or try to aspirate the joint, but I always inject the joint. Lastly, a couple new drugs that are out there. You're being marketed now by this drug, which is pegloticase, which is trade name is Crystexxa. It's basically uricase that's pegylated because our bodies don't make uricase. That's why we have gout. We're one of the few animals that can't break down uric acid. If you try to give a patient uricase, they'll have an anaphylactic reaction to it. So you pegylate it so the patient can't react to it. So they're marketing this. Originally, it was for cases like this where you had tophaceous gout. Now it's being marketed for chronic recalcitrant gout. It's an IV drug. It's got a substantial risk of IV infusion reactions, about 5%, and not an insignificant rate of anaphylaxis with the drug. And it's very expensive, but they're marketing it to podiatrists, thinking we're going to refer more and more patients for it. You're also seeing a movement now to use some interleukin inhibitors for the treatment of gout. Last two slides. Number one is how do you treat them? So they come to my office. I want them to get immediate relief of pain. So I do that wide V block with epi. I don't go planarly. I just do it wide dorsally, a little bit dorsal medially, come back, see some other patients, come back, and then inject them and try to aspirate the joint. As far as colchicine goes, if they have chronic kidney disease, of course, no matter what you pick, it's not good for kidneys, right? Anti-inflammatories will block renal prostaglandins, can exacerbate renal dysfunction. So you give them 0.3 to 0.6 milligrams twice a week. If you use anti-inflammatories, again, you're playing with their kidney function. Glucocorticoids you could use as far as kidneys go, but be careful. You got to tell them it's going to elevate your uric acid or your glucose levels. As far as allopurinol goes, you got to lower the dose. So if they have chronic kidney disease, it's 50 to 100 milligrams daily. And again, you're going if you're gonna give them allopurinol, be careful because you may exacerbate the gout and make it even worse when you first start your rate-lowering therapy. I look at their drugs. If they're taking something like hydrochlorothiazide or something to elevate uric acids, I tell them, well, I'm going to get a letter back to you. I'm going to get a note back to your primary, but you might want to talk about them. If you'd rather blow out their liver than their kidney, then you could give them febuxostat. But again, uricase, pegylated uricase. And then lastly, the dialysis patient. That's another difficult one to pick. And so if a patient's on dialysis, your best choice is to use oral steroids. And the dose you give is up to you. Most podiatrists seem to write for these little dose packs. I don't think that's enough. So personally, I give 30 milligrams of prednisone. I give it for 3 days, and I taper down 5 milligrams every day. And I do that for most things. So I'm not big on these prednisone dose packs or these short little 2 and 3 or 4 and 5 days dose packs. But again, you've got to watch it. So in summary, there are a number of bone and joint disorders that you see more commonly in the diabetic patient. Some of them are unique, not unique, but much more common in the diabetic patient, like Charcot joint. Some of them are seen with increased frequency, such as gout. And you want to be aware of the fact that your type 2 diabetic who's older frequently doesn't get a classic podagra. They have more chronic pain. You could easily mistake it for a biomechanical problem, and be careful of gout in the perioperative period. Make sure you keep control of that patient, because if they end up in an ER, they're going to hear diabetic, they're going to hear surgery, they're going to look and see swelling, redness, drainage, pain, and they're going to, and God forbid they have x-ray changes, then they're going to declare it osteo, and the patients end up with amputations and treatments that get the patient in trouble, and sometimes medical legally gets you in trouble. So you've got to keep control of these patients. Thank you.